Let's dive right into this explainer on mastering daily inpatient documentation and perfectly aligning it with the 2026 AHIMA and ACDIS query standards. Look, if you're involved in hospital care in any capacity, whether you're a clinician on the floor, a medical coder, or a clinical documentation integrity specialist, you already know the medical record is the ultimate source of truth for patient information. So today, we're going to bridge that critical gap between providing phenomenal bedside care and documenting it in a way that is both clinically bulletproof and totally compliant. It's a high-stakes balancing act, right? You're walking this razor-thin line between capturing the true clinical acuity of a patient and accidentally leading a provider with a non-compliant query. Every single day in a hospital, patients generate massive amounts of data. But if that data isn't clearly documented, or if a CDI specialist tries to clarify the record using biased, leading language, the entire chart goes out the window. So we're going to break down exactly how to keep the clinical truth front and center at all times. Here is our game plan. First, we'll hit the daily inpatient workflow. Second, adjusting inpatient daily orders. Third, specialist consultation notes. From there, we'll cover surgical and procedural documentation, followed by CDI concurrent query standards, and finally, we'll wrap up with crafting compliant queries. Basically, we're following a patient from their daily progress notes all the way to how we compliantly query that documentation under the strict new 2026 standards. Section 1, the daily inpatient workflow. We're starting right at the bedside with the daily progress note, which is absolutely the heartbeat of inpatient communication. When a provider rounds on a patient every day, the goal isn't to rewrite the entire admission history from scratch. It's about seeing exactly how the patient is responding to therapies and catching any brand new problems the moment they pop up. And to systematically track those responses day in and day out, we rely on the classic SOAP note structure. Subjective is simply what the patient or their family tells you. Objective is the hard data, the vitals, the lab results, your physical exam findings. You then synthesize all of that into your assessment and outline your next steps in the plan. This framework is a lifesaver because it ensures literally nothing falls through the cracks during a chaotic hospital shift. The crucial takeaway here is that you're documenting the active evolution of the patient's condition. A fantastic, straightforward technique is just asking the patient, "Hey, do you feel better, worse, or about the same as yesterday?" If they came in for urosepsis, your note needs to clearly track if their fever is finally breaking and if that white blood cell count is dropping. You are painting a dynamic picture of their progress, or lack thereof. Section 2, adjusting inpatient daily orders. That daily progress note we just talked about, it directly informs how we adjust the patient's actual orders. Your progress note and your daily orders have to be perfectly synced. You simply can't change a treatment plan in your written note without putting in the corresponding order to make it actually happen on the floor. Anytime there's a shift in the care plan, a new order has to be written to either modify or discontinue the old ones. For instance, if your SOAP assessment notes that a patient's breathing is way better today, you have to write the order to discontinue their continuous oxygen or step down their vital sign monitoring. Remember, an order stays live until a new one explicitly replaces it, so this daily maintenance is absolutely critical for patient safety. Section 3, specialist consultation notes. Sometimes a patient's evolving condition gets really complicated and requires expertise totally outside the admitting provider's wheelhouse. That brings us to consults. Say our patient with diabetic ketoacidosis suddenly develops a really nasty complex leg infection. We need an infectious disease specialist, STAT. But how these two providers interact on paper matters immensely. It really boils down to a clear division of labor. Think of it like a ship. The primary doctor is the captain, steering the overall vessel and specifying exactly why they called for help. Do they just want an opinion, or do they want the specialist to actively manage the leg infection? The consulting specialist then comes aboard, skips the general admission fluff, and dives straight into a highly targeted history, exam, and specific recommendations for their exact discipline. Section 4, surgical and procedural documentation. Now, if our patient needs to be rushed to the operating room, the documentation requirements shift dramatically. Surgery introduces a massive amount of acute, immediate risk, and the paperwork has to keep pace with the lightning-fast speed of transferring a patient from the OR into the recovery room. The timing and purpose of these different surgical reports are so important. A full dictated operative report is incredibly detailed, sure, but it takes time to get transcribed and hit the chart.
That's exactly why the brief operative note exists. It's jotted down immediately so the post-anesthesia care unit, the PACU, knows exactly what just happened inside that OR and what specific complications they need to watch out for right this very second.
There's a mandatory checklist of non-negotiables for this brief op note. The recovery team meets to know the estimated blood loss, or exactly where surgical drains were placed, so the nursing staff knows how to manage the patient's fluid volume and wound care in those critical first few hours. Without this immediate note, the recovery team is literally flying blind. Section 5. CDI Concurrent Query Standards. Okay, let's look at all of this documentation through the lens of a clinical documentation integrity specialist, using the 2026 AHIMA and ACDIS guidelines. This is where bedside clinical care collides with coding and compliance. While the patient is still in the hospital, CDI specialists are concurrently reviewing these daily progress notes, the consults, and the operative reports. And what they are doing is clinical validation. This means a diagnosis sitting on the problem list just isn't enough on its own. It has to be backed up by hard clinical indicators like lab results, imaging, or very specific provider assessments. If a doc writes acute respiratory failure in their assessment, but the objective data shows the patient is sitting comfortably on room air with a totally normal respiratory rate, well, we have a clinical validation issue. The diagnosis and the objective data absolutely must align. The whole point of CDI is supporting provider autonomy and clinical truth, not just forcing a specific diagnosis to get better billing. The 2026 guidelines make it explicitly clear. Queries are educational, clarifying tools. They are never meant to corner a provider into selecting a higher-paying DRG. The provider is the ultimate authority on the diagnosis, but their documentation must clearly reflect the real clinical indicators that led them to that conclusion. Section 6. Crafting Compliant Queries. So how do we actually construct these queries when the documentation is ambiguous? Honestly, writing a compliant query is an art form. You have to point out a glaring gap in the documentation without actually telling the provider how you want them to fill that gap. A compliant query must never use language or formatting that guides the provider toward a preferred diagnosis. Even the subject line of your message in the electronic medical record matters. If you title it Query for Acute Kidney Injury, you're planting the diagnosis in the provider's head before they've even reviewed the clinical indicators. You have to keep it strictly neutral, like respiratory status. When you're building a multiple-choice query, there's a formula to guarantee you're compliant with the 2026 standards. You extract the clinical indicators, like quoting the exact lab value, without adding your own spin. If the heart rate is 120, you literally write heart rate of 120. You do not write tachycardia. You never, ever mention how the answer will impact hospital reimbursement, and you always leave room for the provider to arrive at their own medical conclusion. Now, keep in mind, unable to determine represents true clinical uncertainty, and it's actually a mandatory option for present on admission and yes-no queries, ensuring providers are never forced to just guess. A yes-no query is only for clarifying something already documented. For almost everything else, use multiple choice. And that multiple choice list has to contain only clinically relevant answers, plus an other option for the provider to write in their own thoughts. As we wrap up this explainer, I want you to ask yourself that question. Every SOAP note, every adjusted order, and every operative report serves as the permanent voice of the patient's medical journey. When CDI specialists and providers work together compliantly, using non-leading queries backed by rock-solid objective clinical indicators, they create a record of clinical truth that stands the test of time. Thank you so much for joining me for this breakdown, and please like, share, subscribe to Decode Healthcare with Harshal.